Hi, everyone. This is E. David Crawford, and I am editor-in-chief of Grand Rounds in Urology. For the past 5 years, I've had the opportunity to attend a meeting that is sponsored by Admitech and Dr. Faye Stern, who is the CEO of the Admitech Foundation, and it's entitled The Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. This event and the presentations over the years have been some of the best I have witnessed in prostate cancer, covering the spectrum of aspects of the disease, from controversies in early diagnosis, imaging, a role of radiology and MRI and various other things, and treatments and molecular markers, and you name it. I asked Dr. Stern if she would do us a favor this year, and that is to summarize the many talks that were given, sort of take-home messages for us in Grand Rounds in Urology, in about 20 minutes. And she did that, and I want to thank her for doing that. And so I'm going to turn it over to Dr. Stern, who will begin by discussing the 5th Global Summit on Precision Diagnosis and Treatment of Prostate Cancer, which was held in September of 2021. Dr. Stern.
Thank you for the opportunity to present the key highlights of the 5th Global Annual Summit on Precision Diagnosis and Treatment of Prostate Cancer, a virtual event of September 2021. Annual Summit was established since 2016 by Admitech Foundation, a non-profit organization and creator of the Manogram Project. We are leading national and international programs in prostate cancer research, medical education, public awareness, and advocacy to advance patient care and reduce health disparities. GRU has been serving as our media partner since 2019. Prostate cancer screening has been successful in reducing mortality by more than 50% and emerged as one of the most successful screening programs in cancer care. Since 2016, our annual summit has brought together the key international opinion leaders representing every imaginable clinical expertise to address fundamental challenges in patient care, to develop accurate diagnostic tools for improving risk assessment and reducing overdiagnosis and overtreatment of subclinical prostate cancer, as well as underdiagnosis and undertreatment of aggressive, potentially lethal disease. To integrate anatomic, biologic, and histologic diagnostics, liquid biomarkers, imaging, genetic cancer profiling, proteomics, standard and advanced pathology for a comprehensive approach to patient evaluation. This integration in turn requires bioinformatics and machine intelligence to support complex data analysis for planning of patient care. To integrate precision diagnosis with precision treatment for optimal patient management strategies. To stimulate discovery of novel targets for imaging, biomarkers, drug development, and clinical therapeutics. Our approach includes building a multidisciplinary consensus on the best emerging clinical practices and research priorities, educating medical community and general public, and expediting transfer of promising innovations to patients. Summit 2021 program consisted of 4 sessions and 2 panels. Session 1 was focused on men before diagnosis of prostate cancer. Session 2 on patients with localized, newly diagnosed, and recurrent disease. Session 3 on men with advanced prostate cancer. Session 4 on image-guided, minimally invasive focal procedures. Also, we had a panel on health disparities and a panel on bioinformatics, machine and deep learning, and artificial intelligence. As mentioned, session 1 was dedicated to men prior to diagnosis of prostate cancer. For screening, PSA is here to stay. The most important development in screening is baseline PSA testing in men at midlife, starting at the age of 45. In most men, baseline PSA is lower than 1 and indicates a low risk of lethal prostate cancer long term. In a minority of men, baseline PSA is greater than 1 and predicts higher risk of lethal prostate cancer. The growing evidence indicates that baseline PSA may trump other risk factors, including race or family history. For non-invasive diagnostic evaluation, we have seen a significant and rapid progress in both clinically accepted and emerging liquid biomarkers using blood and urinary testing. These biomarkers have been shown to improve prediction of aggressive prostate cancer and selection of patients for biopsy when combined with PSA screening. More recently, testing of blood and saliva for germline mutations has been recommended for men with family history of aggressive prostate cancer, and I will talk about this later. In imaging, MRI and related PIRAT scoring for risk assessment have become a new standard of care. Advanced ultrasound has an exciting potential, particularly when it will be integrated with MRI. Preliminary data show a promising role of molecular imaging such as PSMA prior to biopsy, but further research is needed. We have seen compelling data on integrating liquid biomarkers and imaging for improved diagnostic performance and selection of patients for biopsies. Liquid biomarkers can be easily administered in any doctor's office, while high-quality MRI requires specialized clinical settings. Further, as Dr. Matt Cooperberg pointed out, liquid biomarkers appear to have a higher negative predictive value in this patient population. During our summit, many leading urologists presented their clinical use of liquid markers prior to MRI. However, more research is needed on the sequence of testing, and Dr. Robert Reiter of UCLA and other investigators have undertaken clinical trials to address this issue. Given all the advances in imaging and liquid biomarkers, our speakers suggested that patient selection for biopsies based on PSA screening alone must end. For biopsies, two advances have been highlighted. Perineal approach expected to reduce infections and currently under investigation in multi-center trials, and fusion of MRI with ultrasound for a combined image-targeted and systemic tissue sampling. This slide shows the importance of MRI for identifying index lesions and guiding biopsy needles. I think it is fair to say that blind biopsies are slowly and surely shifting to the dustbin of history. We are proud to be leading development, PIRAT standardization, clinical evaluation, and large-scale implementation of precision MRI since 1998. Session 2 was focused on localized prostate cancer, newly diagnosed and recurrence. Our summit underscored the importance of blood and saliva analysis for germline mutations, particularly for men with family history of aggressive prostate cancer, diagnosis of high risk or advanced prostate cancer, Ashkenazi Jewish ancestry, and family history of other cancers, including breast, genitourinary, gastrointestinal malignancies, or melanoma. Genetic counseling is preferred before testing if family history is present, and after testing when it is positive for mutations. Research on radiogenomics has been highlighted by Drs. Alan Pollack and Sanosh Poonen, University of Miami, since Summit 2016. When image-guided histology shows cancer, the tissue samples can be examined for gene expression. In parallel, quantitative image analysis or radiomics is performed. The integration of radiomics and genetic tissue profiling is termed radiogenomics. Our annual summit has played a seminal role in recognizing the importance of radiogenomics for optimizing patient management strategies. Over 5 years, we have seen a shift in radiogenomics from the fringes of research in 2016 to the center of the discussion on the future of precision care in 2021. Emerging data indicate that the future of patient evaluation may be based on multiple integrated diagnostics, coined as multi-omics. Matt Cooperberg and his team at UCSF showed that 15% of low-risk cases, as assessed by standard clinical diagnostics, including histopathology, had high-risk genomic features. Dr. Eric Klein of Cleveland Clinic highlighted prostate cancer as a biologic rather than a histologic disease. He pointed out that histology is useful for detecting a small volume, low-risk prostate cancer and clear-cut, high-risk disease. However, histology is less useful for the majority of cases, including large volume, low-risk prostate cancer and intermediate-risk disease. And that's where genomic testing can make an important impact on personalizing patient care. Dr. Klein also highlighted 2 current pillars of precision diagnosis: MRI for visualization, characterization, and staging of prostate cancer, and genomics for underlying biology and prediction of progression. Over the last few years, we have also seen important advances in ultrasound, molecular and multimodality imaging, and their potential role in patients with localized prostate cancer. Currently, several companies offer genetic cancer profiling, and we hope to see its accelerated utilization in the next few years. Dr. Stephen Rowe, Johns Hopkins, reviewed current imaging tools. MRI lesions, particularly Pyrite 3, may appear as similar for benign and malignant lesions. In metastatic disease, CT and standard bone scan cannot detect small lymph node involvement or distinguish benign from malignant bone disease. He described the promise of molecular imaging with PET PSMA, which detects prostate cancer lesion in most patients and correlates with tumor aggressiveness. Dr. Andrei Ayagaru of Stanford University showed close correlation between PET PSMA with standard histopathology for intermediate and high-risk cancer. Dr. Ayagaru also showed that PET PSMA is superior to traditional bone scan for advanced prostate cancer. On the left, we can see a standard bone scan showing limited bone metastasis. On the right, PSMA PET video demonstrates a much more extensive disease. Admitech Foundation supported development of molecular imaging, PET PSMA in particular, since 2001. It has been rewarding to see FDA clearance and growing clinical implementation of this technology over the last few years. Dr. Jerry Andriol, at that time of Washington University, had won our abstract competition for his work in Axumin PET-CT imaging and its impact on patient management. This study was based on 2 clinical trials conducted jointly with University of Leeds and Blue Earth Diagnostics, involving 146 patients who were all intended to undergo ADT prior to imaging. Axumin detected lesions in 58% of these men. After imaging, ADT plan was eliminated in as many as 40% of these men due to negative results, or prostate cancer localized to the prostate bed. In general, Axumin imaging changed patient management plan in as many as 64% of these men. This also included improved target definition for salvage treatment. In summary, session 2 demonstrated advances in non-invasive and minimally invasive diagnosis and treatment. For diagnostic advances, We have seen the role of germline mutations for predicting aggressive prostate cancer. We have also discussed the role of genetic cancer tissue profiling for improving risk assessment compared to standard histopathology. For initial disease, MRI has become a standard for staging, though we need to see more programs in quality assurance. We have seen rapid advances in molecular and multimodality imaging, and yet more research is needed. Further research is also needed for integrated diagnostics or multi-omics, radiogenomics, proteomics, advanced histology. MRI target biopsies rendered risk assessment based on the number and percent of biopsy cores occupied by cancer largely irrelevant. This highlights the need for new risk assessment strategies, perhaps multi-omics-based nomograms. We have seen the importance of precision diagnostics for individualizing treatment. It is intriguing to see the emerging role of systemic treatment when added to standard care for men with aggressive localized disease. Session 3 was focused on precision oncology for advanced prostate cancer. Our speakers presented rapidly expanding discovery of prostate cancer targets for biomarkers, imaging, drug development, and clinical therapeutics. Dr. David Naines of Cornell reviewed the role of liquid biopsy, including biomarkers, circulating tumor cells, DNA, and RNA for patient evaluation. Multiple speakers demonstrated the role of molecular and multimodality imaging for staging and treatment planning. For treatment, as mentioned, Summit pointed out the importance of molecular imaging for improving patient selection for ADT to avoid iatrogenic castration resistance and decrease morbidity. Dr. Daniel Petrilak of Yale highlighted the importance of precision diagnostics for precision treatment. For example, detecting germline mutations for administering PARP inhibitors. He pointed out that about 15-20% of his patients currently undergo precision treatment based on precision diagnostics. We have also seen the emerging role of immuno-oncology and novel targets such as epigenetic modulations and lineage plasticity. Dr. Philip Koo of MD Anderson Cancer Center presented current state-of-the-art and future vision for theranostics, integrated molecular imaging and treatment. This targeted radiotherapy using PSMA may represent an exciting new option for metastatic disease. Session 4 of our summit demonstrated growing evidence that image-guided, minimally invasive procedures provide comparable cancer control with significantly reduced complications compared to standard treatment. Precision diagnosis is critically important for risk assessment and patient selection for image-guided treatment. While MRI has been used most extensively, we have seen the emerging role of advanced ultrasound, molecular and multimodality imaging, and radiogenomics multi-omics for target definition. More research is needed for improved patient selection, monitoring, and outcomes. Almost every speaker in this session highlighted the importance of definitive randomized clinical trials for shifting image-guided treatment from the current experimental stage to routine clinical care. Admitech has been leading development and clinical evaluation of image-guided, minimally invasive treatment since 1998. When validated, these tools will become an important future addition to patient management options, particularly for many men who end up in a gray zone where risk assessment leaves clinical questions regarding the appropriateness of active surveillance or necessity of the immediate radical treatment. We hope to see an increased pace of the clinical validation and adoption of minimally invasive treatment in the near future. Our health disparities panel showed that MRI is of particular importance to Black men who are more likely to have cancer lesions in the anterior prostate, not accessible by blind systemic biopsies and digital rectal exam. This panel acknowledged emerging data on the biologic differences in early stages of prostate cancer between Black and white men. And yet, based on the large-scale studies from veteran administration and military medicine, our experts concluded that equal access to care is the key factor in achieving equal outcomes. Multiple experts from urology, radiology, and industry underscored the importance of digital health, bioinformatics, machine and deep learning, artificial intelligence for every aspect of patient management, screening, diagnosis, predictive modeling, treatment planning, care, and follow-up. There was a clear consensus that the era of only cognitive data analysis and traditional patient information management is over. Bioinformatics and machine learning are expected to be important not only for clinical practice, but also for clinical research and trials. For example, by creating and analyzing patient registries or validated data sets. Summit 2021 was made possible by the state of Massachusetts and the Donohoe family, courtesy of National Philanthropic Trust. Our sponsors, including platinum sponsors, Felix, Telix Pharma, gold sponsors, Astellas, Pfizer, General Electric, Lantheus, Siemens. Silver sponsors, Amgen, J&J, MIR Scientific. Bronze sponsors, AAA, Blue Earth, Cleveland Diagnostics, Exact Imaging, Exact Sciences, and OPCO. Exhibitors Hitachi, now Fujifilm, Kyolis, Perineal Logic, Profound Medical, and grant from PHRMA, and our summit governing and management team. Please join us for the next summit taking place on September 22nd to 24th this year virtually. You will learn about the cutting-edge clinical advances and take part in creating a roadmap for the future of precision care. Thank you for your attention.